Thank you, sir. Respected chairpersons, my co-speakers, and my dear colleagues, very good afternoon. And you all know there is a more important link between diabetes and infection. Many a times you diagnose diabetes because of some infections, and also the infection triggering diabetic ketosis or ketoacidosis. This you would have come across many a times. Coming to diabetes and infection, infection causes considerable morbidity and mortality in patients with diabetes, and this may precipitate metabolic derangements, and conversely the metabolic derangements again aggravates the infection. And diabetes increases the susceptibility to various types of infection which may be dormant, so far gets triggered or flared up during diabetes. Why this diabetes increases the infection rate? It's because of the lower secretion of inflammatory cytokines, glycosuria acting as a culture media, the GIT dysmobility, hyperglycemia increasing the virulence of the infections, and large number of medical interventions in diabetes, neuropathy lessening the sensation and causing most injury, angiopathy, antioxidant system depression, disorders of humoral immunity, that is neutrophil function, lymphocyte, all coming down. And on the other hand, if you see infection, this increases the production of stress hormones, which are all diabetogenic, and increases the production of cytokines, which all leads to insulin resistance, and infection of beta cells diminishes the insulin secretion, leading all to hyperglycemia. What is the level at which we need to maintain the blood sugar? Of course, it is 180. At least we need to maintain better. It has to be less than 140. And sometimes the blood sugar we are maintaining in spite of that the patient is not getting control of infection. This is because of its long duration of diabetes causing the microvascular and macrovascular diseases with a resultant poor tissue perfusion and increasing the risk of infection. And the ability of the skin to act as a barrier to infection is compromised when the diminished sensation of diabetic neuropathy results in recurrent unnoticed injuries. And coming to the local factors for aggravation of infection in diabetic patients is the susceptibility to infection is increased, as I said, because of the vascular disease, neuropathy, hyperglycemia, neuropathy causing foot ulceration, and with infection, autonomic neuropathy involving the bladder where there is stasis, urinary retention and infection, chronic cystitis, and vascular insufficiency causing tissue hypoxia and growth of anaerobic organisms. And some infections are mild and normal. In diabetic, it happens to be fatal. And hyperglycemia and acidemia both exacerbate the impairments in humoral immunity and polymorphonuclear leukocyte function and lymphocyte functions, but are substantially reversed when the pH and blood glucose levels return to normal, like leukocyte adherence, chemotaxis, antioxidant activities, all are diminished but gets back when you revert to normal blood sugar. Remember, the response to vaccine is maintained in a diabetic. Commonly, we come across these infections, that is pneumococcal, wound, surgical site infections not getting healed, and urinary tract infection taking a long course, and also the skin infections. Commonly, if you see the infections which are strongly associated with diabetes or mucormycosis, which you would have heard of that during the COVID time, the malignant otitis externa, the emphysematous pyelonephritis, emphysematous cholecystitis, and the infections which are caused by our therapeutic intervention or during insulin therapy, they can go in for insulin injection abscess, penile implants causing infection, organ transplants, increasing the insulin resistance because of the drugs used, and infection associated with diabetes as such. Other infections which are possibly related to diabetes are the UTI, bacteriuria, pyelonephritis, renal papillary necrosis, renal abscesses, and perinephric abscesses. We do get fungal infections, UTI and other fungal infections, very much common in diabetic, staph aureus infections, and soft tissue infections like necrotizing fasciitis, venous gangrene, synergetic necrotizing cellulitis, non-clostridial anaerobic cellulitis, etc. Is there any common site of infection which can occur in a diabetic? The most common site is, of course, the skin and urinary tract, the staph follicular skin infections, superficial fungal infections, cellulitis, erysipelas, and oral or genital candidal infections, low urinary tract infections, and acute pyelonephritis are seen with greater frequency. Of course, you will be coming across in all your diabetic patients more common in your practice. Of course, the one which is exclusively seen in diabetics, the malignant otitis externa, rhinocerebral mucormycosis, and the emphysematous pyelonephritis. This rhinocerebral mucormycosis occurs specifically in DKA patients because it needs the ketone bodies, and CT or MRI confirms the diagnosis, and also you can take a biopsy or scraping from the discharge, stain it with potassium hydroxide, broad asteptate, branching hyphae. I'm not going to discuss about the management because madam next she'll discuss about the management. Coming to malignant otitis externa, there is otalgia, persistent external otitis, extensive granulation tissue with radiological evidence of erosion of the canal, and emphysematous pyelonephritis, of course, mainly more than almost 90% is associated in diabetic patients. There is a gas in the X-ray or CT, you can find out easily. Perinephric abscess caused by gram-negative bacilli, predominantly the E. coli, is again 1/3 of them occur purely in diabetic patients. And emphysematous cholecystitis, again this is very common in diabetic. Plain film of X-ray or CT shows gas inside. Often it is complicated by gallbladder gangrene or perforation. And during insulin therapy, insulin as such is not causing any problem infection because it contains a preservative, and the antibacterial activity is still in some patients, but in unhygienic patients, because of the unhygienic conditions, they can get into infections, rarely abscesses also. During the penile implants, again they can get urethral injury and subsequent infections, and they'll have tenderness during erection. That means there is mechanical malfunction and you need to remove the prosthesis. During renal transplant or other transplantation, islet transplant, we do give steroids like prednisolone, methylprednisolone, dexamethasone, hydrocortisone, or immunosuppressive agents like azathioprine, cyclosporin, rapamycin, tacrolimus, and sirolimus. All these increases the insulin resistance and interferes with the glucose control, further aggravating. And bacteria, the symptomatic and asymptomatic, this is common because of the older age, neuropathic bladder, and as I said, the complications, macrovascular, and the degree of glycemic control. Of course, the organisms are commonly E. coli, followed by the Klebsiella, coliform, Proteus, and other organisms. And commonly acute bacterial cystitis, there is increased frequency of urine with dysuria and suprapubic culture diagnosis, clinches the diagnosis. Usually it is E. coli Proteus, and it's more common in diabetic women than non-diabetic women. The acute pyelonephritis, there is fever with flank pain. Of course, we find out by culture the same organisms. Emphysematous infection should also be considered. If it is emphysematous, again the same symptoms with poor response to antibiotic. Here again X-ray or CT done, and sometimes emergency nephrectomy may be needed. Perinephric abscess, again fever, flank pain, poor response to antibiotics. You can do X-ray or CT, and surgical drainage usually is required. The fungal cystitis behaves in the same manner like bacterial, but it's diagnosed by urine culture. It's usually Candida species, and it is very difficult to distinguish by colonizers from other infections. In, of course, men, the urethra is long, they do not get much infection. If at all they get, you should consider prostatitis, epididymitis, and urethritis also. Perianal abscess is a painful condition in which collection of pus develops near and around the anus, and it's very common in diabetics. Periungual abscess and fungal infections, oral candidiasis, especially in the denture users, and uncontrolled diabetes, tinea versicolor and capitis. Vulvovaginal candidiasis, of course, you all will be seeing more common in your practice whenever the blood sugar goes out of control, or we diagnose diabetes when they come out with these conditions, balanoposthitis, and genital pruritus, and pelvic inflammatory diseases, again very common in uncontrolled diabetes, and phimosis. You should look for the phimosis. Any degree of phimosis again causes infection and interferes with the control. The necrotizing fasciitis, which is necrosis of the fascia and subcutaneous tissue. And carbuncle is a red, swollen and painful cluster of boils that are connected to each other under the skin. This was very famous even started in my grandfather's days. They used to say it as, call it as Raja Pilavai. This occurs solely in diabetic. And the funous gangrene, it is a fasciitis affecting the male genitalia, more common in diabetic. The non-clostridial anaerobic cellulitis, it is the infection of the skin and soft tissue. It doesn't involve the muscles and crepitations are present. The synergetic necrotizing cellulitis, there is thin malodorous dishwater pus with surrounding blue-gray gangrene is seen. Of course, the gram-negative organisms, anaerobic and obligative facultative anaerobic organisms all are present. And intertrigo, toes and fingers, this is very common. You have to, if the blood sugar is not getting control, you need to see to all this. There is warm, moist skin in the areas of the web spaces between the toes and fingers, especially in the toes. Please see to it. In overweight individuals, this is very common, and interdigital space should be maintained and avoid prolonged contact with water. And these are all, of course, you all know trophic ulcers present in diabetes. And the cause for infection, recurrent foot infection, is neuropathy, atherosclerosis, that is vasculopathy, and infection. It can lead to gangrene. And tuberculosis and diabetes, the very specific feature is it is multilobular, and usually you'll see the upper lobe getting involved, but in a diabetic you can see the middle or lower lobe getting involved. If you see any PT patients with middle or lower lobe involvement, please test for diabetes in them. And it also present with cavities. Coming to gastrointestinal, the Helicobacter pylori are related to microangiopathy, neuropathy, and microalbuminuria in patients with diabetes, and also coronary insufficiency, cerebral occlusive vascular disease. All these can occur. And oral and esophageal candidiasis, the rhomboid glossitis, central papillary atrophy, atrophic glassitis, denture stomatitis, pseudomembranous candidiasis, and angular cheilitis, all these can be present. And periodontitis, this is 4 times more common in diabetes, and it is considered as the 6th most common complication of diabetes. And intertrigo, that is in between the skin folds, because of the perspiration, sweating, they can get infection, and it's an inflammatory disorder. Dermatophyte infections or fungi requiring keratin for growth causes superficial infection of the skin, hair, and nails. Pyomycetes is a bacterial infection of the skeletal muscle which results in a pus-filled abscesses. And of course, HIV, the increased risk of developing diabetes is related to the HIV treatment, that is the heart. Some patients were reported to develop even type 1 after immune restoration during the highly active antiretroviral therapy. And all these eye infections you do come across. In fact, diabetes is the primary cause of blindness in adults between the age of 20 and 74. And hepatitis B regarding that the diabetic patients who share a common blood glucose meter, that is pricking, they may be in the same family using without cleaning and in disinfecting between uses, and during finger stick they get infected with this. Hepatitis C, they have a more severe liver disorder and increasing fibrosis due to the impairment of beta cell response, liver damage leading to an abnormal glucose metabolism and further aggravating the insulin resistance. Enteroviruses, you are all aware that Coxsackie B4 and B3 viruses play an important role in the development of type 1 diabetes. And of course, the surgical gite infections are very difficult to get cured or subside because of the uncontrolled blood sugar. We need to maintain the proper blood sugar. And other common types of respiratory diseases are our cystic fibrosis, emphysema, and pneumonia. And you all are aware that at the time of COVID, it was difficult to treat the patients who were having hypoglycemia. The hypoglycemia got aggravated and more deaths were reported only in the diabetic patients. So there is defective innate immunity and immune system, defective adaptive immune system, other host-specific factors, all increasing the infection and leading to further aggravating the insulin resistance and leading to beta cell dysfunction, aggravating the diabetes control, or resulting in diabetes. Again, this becomes a vicious cycle. Both these, diabetes and infection, influence each other. And as I said, these infections are common in respiratory, urinary tract, soft and skin and soft tissue, and in the foot. And prevention, of course, it is by public health measures and vaccination, and also with adequate antibiotics. The key recommended vaccines include the annual influenza vaccine, pneumococcal to prevent pneumonia, and the hepatitis B, Tdap, and also shingles once in 5 years. So in the infection in diabetic, it needs first and foremost good glycemic control, good glycemic control, good glycemic control with adequate proper debridement of the wound, and antibiotics to cover all three, that is the gram positive, negative, and also the anaerobes. Thank you.